Hello everyone, Dr. Scott Sigmund, orthopedic surgeon here in North Chelmsford, Massachusetts, where we're going to talk about our technique today of superior capsular reconstruction. I've been doing this operation for about 2 years now. It's been a major evolution for me. I will tell you, it was a very complex, time-consuming surgical intervention when I first started. The idea of this procedure today in the video that we're shooting is to show a highly reproducible, efficient method of superior capsular reconstruction, really more creating a rotator cuff repair rather than the standard complexity of the multiple sutures associated with superior capsular reconstruction. So I'm a huge believer in the lateral decubitus position. I've tried it both ways. The lateral decube gives me that traction here, opens up the subacromial space for me, and truly gives me better visualization as I'm placing the graft. The entire surgical intervention can be done through a standard posterior portal. This is my standard lateral working portal over here, and then we're going to make 2 percutaneous portals here to be able to place our glenoid suture anchors, and these will also then be used for graft passage and suture passage for the lateral aspect of the graft onto the footprint as well. You can see here's some remnant of some anterior cuff. Biceps is down in here as well, and then posterior cuff is into this direction over in here. And then down in here is our glenoid. Here's anterior glenoid, and then this is the posterior glenoid. So this is an irreparable rotator cuff in our hands. Here's the footprint of the rotator cuff that we've developed. Most importantly here, I'm going to clean out this bursa laterally. It's super important because when you're putting in your anchors in, both to the footprint as well as when you're creating your bridge with the suture, you want to make sure you have good visualization into this lateral humeral head as you're actually playing and putting in. So that's where we are at this point, and now we're going to start progressing into the next stages. All right, so here what we've done now is we're making a percutaneous portal here so that we can get into the field of the anterior glenoid. This is the same incision here that we're going to wind up using for suture passage later on as well. Knife, please. So I'm going to elect to use the Griffin MyTech system. Excellent. Take your mallet. Down to the laser line. And it looks like we have good bone purchase. Now at this point, this is a double-loaded anchor. What I like to do is pull one of the sutures at this point right now, so that way we know where we're working. So I'm going to pull the purple, and we're going to leave the blue. Okay, take the knife again, thank you. Again, this posterior portal here is now going to be my working portal for suture placement through the graft when we're ready. Good, that felt like we have good bone throughout. Good, nice hard bone. So what we'll do now, in order to aid our decision making later, is we're going to pull the suture, and we're going to leave the purple one in the back, and we're going to leave the blue one up in the front. So our next move now is to go ahead and get in our lateral row anchors, where we're going to be using tape at this point in order to get really good fixation into our graft. Okay, so at this point right now, I'm a little bit adjacent to the footprint. You can see that right there, articular cartilage. We're going to come in at the appropriate angle here. Excellent. And we're just going to pop our awl out. And you can see here, it just seemed like the best portal to work with here was our anterior portal that we had just used for the glenoid. That seemed to give me the best angle of attack in on the footprint. We can move that suture and tape out of the way as we're ready. Okay, that looks good. So this is a Helix Events anchor with permatape, which comes preloaded with a 2.5 millimeter wide permatape suture, a number 2 permacord suture, which I'm going to remove here, and a utility suture shuttle for passing multiple sutures simultaneously with a single pass. And the reason I like permatape versus fiber tape is because it's less than half the bulk, but wider and less abrasive. And here's our glenoid suture is over here as well. So next what we want to do is we want to go ahead and make our posterior. One of the things that you can do here is, as you can see here from my assistant, she's rolling inwards to give us some improved external rotation. Let me see the awl again, please. And it looks like I may want to come through this same angle over here. We'll see if I can get the right angle. Okay, so now I'm advancing our posterior helix anchor here with a 2.5 millimeter wide permatape that we're going to use for lateral row fixation. We can see here he's got excellent bone. That's making me feel good. So at this point, I'm satisfied that all of our major anchors are in play. What we need to do now is measure the size of our graft so that we're making sure that we're putting it in appropriately, which is a very important portion of the procedure. So ideal suture shuttle is my preferred method. There's lots of methods for doing the appropriate measurements here. But as a general rule of thumb, I find this to be reproducible, relatively easy to use. So what we're going to go to is right here from one anchor, and we're going to advance. And then we're going to basically measure that right there. We're going to come over here, measuring tape, please. So that's measuring about 11 to 12. It's actually measuring about 12 millimeters or so. So we're going to want to err on the side of having a little additional graft here, always for sure. So I'm actually going to take it out to about a 20 here, which gives me about 3 to 4 millimeters on either side of the graft to give me appropriate positioning. So I like that. You can hold that, please. We're going to use the same device now. We'll pop back in, and what we'll do is we'll measure the length of the graft between our two anchors, I should say. So that length looks pretty good there, and that looks pretty good there. So we're going to go ahead and measure that. Holding my thumb on the wheel here, just to give a technique to hold it in place. So this is measuring about 29 millimeters or so from anchor to anchor. So you're going to want to add a little bit of distance to make sure you have enough graft in place. Plus I like a little extra as far as the length is concerned to come down across the humeral head. So we're going to go to about a 35 millimeter in length on this one. So we're graft to graft there. I'm happy with that. I'm going to put my thumb wheel on the wheel here again. Measuring tape, please. Great. So this is measuring about a 19. So we're going to go to about a 25 millimeter wide to wide to make sure we have enough, about 2 to 3 millimeters on either side. As a general rule, I like to select the thickest human dermal allograft available, typically between 3 to 5 millimeters. I'm usually between 4 to 5 millimeters, and I would recommend you consult with your MyTech sales consultant for graft options. We said it was going to be 20 millimeters on the medial side. We said it was going to be 25 millimeters on the lateral side with an overall length of 35 millimeters. You can see here that Kristen is showing us. So that's perfect as far as the sizing is concerned for this graft. With the standard new instrumentation that we have for rotator cuff suture passing, we can pass suture directly through this graft and really position it very nicely. We found with the tape in particular, it can be a little bit tougher to come up and through. So for the holes in which we're going through the tape up and through on the lateral portion of the repair, we will certainly go ahead and develop 2 holes in advance to make sure that we're getting appropriate. We typically will do that about a centimeter or so from the edge, because you remembered we're putting a graft in at about 30 length, where the holes were typically more about 28 to 29. So Kristen's going to go ahead and measure that right now for us and give us an idea as to where those lateral holes are going to go. She can measure the overall length between medial to lateral anchors, or go about 8 millimeters from the lateral edge in this case. That looks good to give us appropriate positioning. Same thing, about 8 millimeters from the lateral edge. What we'll do now is make 2 starting holes in the graft, and that's pretty much all we're going to do as far as manipulation of the graft on the back table. All right, so at this point right now, what I want to do is I want to be able to pass our medial glenoid anchor sutures up and through our graft. So I am not using a cannula at this point. I will use a cannula later for graft or suture or tape passage of the lateral portion of the graft, but at this point I've found that I can actually manipulate the graft in relatively easily. As a general rule of thumb, if I grab all 4 suture limbs at the same time with the same passage, I do not have to worry about developing any type of a suture bridge. We're going to go ahead and just open up that portal one more time to be able to really make sure that our graft is going to pass through in the position that we want it to. And that looks really nice. Espresso 2, Espresso 3, does not really matter, whatever you're comfortable with. But this technique and just passing the suture allows us on the field to be able to put these sutures exactly where we want. Okay. So we're going to be using an anchor-to-anchor technique here. So we're going to use a pulley system to be able to pull the graft down into position. So these are our two posterior, and now we're going to work on the anterior. And we're just going to go ahead and tie a knot outside the joint here. So what I do is I just do a little wraparound here with these two sutures, creating a knot at the base here. And then just tie a few half hitches over top. And there our knot slides into position here. Let me just get this one suture here to come up. Perfect. So we've now slipped our knot down, and this pulley system is going to help to pull this graft into position for us as we're getting ready. All right, can I take that grasper here? This is just a device that I use to help push the graft in, and then we'll go ahead and use the sutures to position it. Yep, I know. That's okay. Okay, good. So at this point, we've actually pulled our graft into position here. We're on our medial side. I'm just going to help to just sort of position this a little bit better to get it out of the way. Take this, please. Just trying to medialize this graft down into position as we get ready for suture passage. Since we're anchor to anchor here, we're going to tie half hitches into position. You cannot do a sliding knot here. Knot pusher. So we'll do 3 half hitches, and then I'll reverse the post to lock it in place. Okay. This is the only time in the case where I'll actually now use the cannula. And so this cannula is going to make sure that as we pass our sutures, we're not going to develop a suture bridge. So this is our anterior permatape that we have here present. I'm going to even those two things out. So now I want to do this sort of like a rotator cuff repair now. The Espresso 3 can be used to pass permatape directly, or like I'm doing here, you can actually shuttle multiple limbs of the tape using the included utility suture shuttle. Okay, so we've now passed our suture loop up and through to our footprint. We've got our tape outside of our cannula. Show me the cannula here. And so what we're going to do now is pass our 2 tapes up and through this looped portion. Okay. And pull the tape up and through the graft, up and out through the front. Okay, so that looks good. We've got our tape up and out through our cannula, and we have to do the same process we did before with our posterior tape. We're going to pass our tapes up and through. We're going to pull our loop up and through the tissue, and voila. We have our sutures up and through our graft in our lateral respect here. So at this point, what we're going to do now is finish off our lateral repair. We're going to grab one of the permatapes from the front and one of the permatapes from the back, and we're going to do a crisscross repair. This is very comfortable and routine for everyone. This is a standard rotator cuff repair that we're all used to doing. So we just want to grab one, and we want to make sure that we don't pull through both. So what we'll do is we'll pull up on one, which is this one here. If I pull up on the other one, we're satisfied that we've got the right one, up and through. Now we want to do the same thing now for the posterior aspect of this repair as well. So we're going to come through and in. All right, so now we're going to find a nice spot for our tape to go in. What we're going to do is we're going to come in with our awl here. We're going to use a Helix Advanced knotless system here to be able to get a good solid repair. He's got good solid bone, which is making me happy. So what you can identify here, you can see, is that Kristen is giving us counter pressure or holding the sutures because, remember, these are sliding through the anchor at this point. So until we fixate this one, we can't get definitive tension on this. So I'm satisfied I'm in the hole. I'm going to give myself a little bit of tension through the tape here. Okay, I'm happy, and now we're going to set the anchor. Excellent. Okay, suture retriever, please. So we're going to grab our remaining anterior suture, And now our remaining posterior suture, or tape I should say. And again, very good bone. I'm very pleased about that. And we're going to go ahead and just tension up here a little bit, both sides. We're good. Excellent. Okay, excellent. So visualizing right now, we've got excellent tension across our entire glenoid. You can see that the sutures are holding very nicely here. And then our graft comes back across the humeral head very nicely, and we have excellent coverage across the footprint. Now the question is whether or not I can try and do a little bit of side-to-side repair here to sort of advance this and make it even better. So here we're going to make an attempt at side-to-side repair. And again, I've seen all these videos where these holes have been dug out in advance of the surgery. But to be honest with you, I haven't really found that to be necessary, Grasper. With the technique of using this suture retriever, or suture passer I should say, you'll see here in a minute, we usually can get a pretty decent bite into the tissue. Grasper. And so with this passage here, I'm able to do a little side-to-side repair and incorporate some of the native rotator cuff into the repair as well. So here we are. At this point, I'm satisfied that we've completed the operation. We've got our medial glenoid anchors holding our graft into excellent position here. Our graft is under very nice tension. We went ahead and did our lateral row using the permatape here, which you can see very nicely. We then went ahead and closed our anterior gap with some of the remnant subscap into the graft as well. All done with an arthroscopic technique. In this type of a video situation, this surgical intervention should be taking you 60 minutes or less as a general rule of thumb. At this point, we're just very pleased to be able to have this opportunity to show you this technique and hope that you guys will be able to use it as well. Thank you. I'm a firm believer that with this repair, what we're doing is we're getting immediate fixation. And so what I typically will do is do pendulum range of motion, early range of motion to the elbow and digits for the first 10 days. At 10 days, if the patient's doing well and their pain is reasonably controlled, we'll start them in a physical therapy protocol. We'll start active assisted range of motion immediately with progression to active range of motion as tolerated without a specific timeline. Many of these patients are coming in at 6 weeks post-op having near full range of motion to their shoulder, already exhibiting significant pain relief compared to where they were preoperatively.